Anatomy and physiology of dental prosthesis supporting structure. Dentists or prosthodontists have to know the anatomy and physiology of the bony structure that support the dental prosthesis, whether that dental prosthesis is a removable partial denture, implant supported partial denture or complete denture, or the dental prosthesis is a complete denture. The osteology or the anatomy and physiology of the bony foundation or bony structure of the edentulous area. It's important to know the support or help in support of the denture and maintain the retention and stability of the denture, and the physiology and anatomy of the mandibular and maxillary foundation area or bony area that support the denture have a direct relation to the impression making procedure, the position of the teeth when it is arranged in the trying procedure, in addition to the contouring of the denture base material of the denture. Associated with the mandibular denture or the bony structures that associated with the mandibular denture include the coronoid process, residual alveolar ridge, buccal shelf area, external oblique ridge, retromolar bud. In addition, the mental foramen, mylohyoid ridge, lingual tuberosity, genial tubercle, mandibular tori. The coronoid process represents the anterior extension upward of the mandible, and it's important in determine the distal extension of the mandibular denture, and during the function of the mandible, the coronoid process may be interfere with the disto-buccal flange of the maxillary denture. When the disto-buccal flange of maxillary denture is too thick or wide, may cause discomfort and distortion of the upper denture during opening the mouth up widely by the patient, or during the lateral movement of the mandible from side to side. It will cause distortion of the maxillary denture due to the thickness of the maxillary denture. And in this case, the disto-buccal flange of the maxillary denture should be thinned by the handpiece to resolve this problem. Alveolar ridge of the mandibular arch represent the residual ridge after extraction of the mandibular teeth and the resolved alveolar process of the mandible. The bone, the bone underlying the crest of the residual ridge is cancellous and regarded as unfavorable for resisting the occlusal applied force from the denture. So the residual alveolar ridge regarded as a secondary stress-bearing area in the mandibular complete mandibular denture. Buccal shelf area extend anteriorly from the position of the frenum, uh, buccal frenum, and extend posteriorly to the anterior border of the masseter muscle. In addition, medially it's bounded by the crest of the alveolar ridge and laterally by the external oblique ridge. The external oblique ridge represents the attachment of the proxinator muscle, so this ridge regarded as a hard area and highly resistant to the resorption during the wearing of the complete denture. In addition, the resorption of the crest ridge, crest of alveolar ridge, cause the flattening of the buccal shelf area, So the buccal shelf area become a dense cortical bone and become a right angle to the vertical occlusal force of the mandibular complete denture. So the buccal shelf area regard a primary stress area in the mandibular complete denture. Ridge extend just above the mental foramen superiorly and distally continue to the anterior border of the ramus. The oblique ridge regard the anatomic guidance for the lateral end of the buccal flange of the mandibular denture, or regard as a limiting extension area of the buccal flange of the complete denture, because to this area, as mentioned before, the attachment of the fibers of the buccinator to this area that interfere with the insertion or the stability of the complete denture. So the external oblique ridge regard as an anatomic guide for the lateral extension of the buccal flange of the mandibular denture. Located at the lateral surface of the body of the mandible between the first and second premolar, in the halfway between the lower border of the mandible and the alveolar crest. After extraction of the teeth and resorption of the residual alveolar process, the foramen become at the crest of the alveolar ridge or the crest of the residual ridge, and in this case the uh, mental foramen and the mental nerve may be compressed by the mandibular complete denture, and in this case either cause sensation for the patient or numbness in the lower lips due to the compression of the denture on the mental nerve or on the mental foramen, and in this case this area should be relieved and regarded as a relief denture area. Area is represent the distal end of the alveolar ridge of the mandibular denture. It's a triangular pod, and the anterior portion of the triangle is keratinized tissue of the remnant gingiva of the third molar, and this area called the pear-shaped pod. The posterior aspect of the triangle represents the insertion area of the fibers of the temporalis tendon and the buccinator and superior constrictor muscle, in addition to the pterygomandibular raphe. The underlying bone of the posterior part, due to the insertion of the muscles which are buccinator as mentioned and temporalis muscle, become a dense cortical bone, and this is highly resistant to the resorption, and the denture should be covered the retromolar bud area because of the support and lacking of the long-term cortical bone resorption at this area. From the lingual surface, we found the mylohyoid ridge, which represents the insertion area of the mylohyoid muscle, and this ridge extends anteriorly from the inferior border of the mandible and extends distally to flush with the lingual surface of the mandible. This area was covered with a thin mucosa, and during the insertion of the complete denture, mandibular complete denture, may be cause ulceration for the patient or sensation in this area due to the thin mucosa that cover the mylohyoid ridge. So it's regard a relief area of the complete denture. In addition to the undercut that lie inferior to the mylohyoid ridge may be uh, important in the retention of the complete end of the mylohyoid ridge, and with an irregular bony prominence that represent the end of the mylohyoid ridge or distal to the mylohyoid ridge, and this irregular bony prominence also need to be relieved because it covered with a thin mucosa and cause pain or ulceration for the patient and regard as a relief area of the denture. To the mylohyoid ridge, there is a 2 to 4 number of tubercles on the lingual surface of the body of the mandible at the midline, and when the alveolar ridge is severely resolved, the genial tubercles become on the center of the residual ridge and should be relieved because it causes sensation and ulceration for the complete denture. The mandibular tori is a bony prominence that located also on the lingual surface of the mandible at the area of the premolars and may be extended to distally to the molar area, and when the tori is small should be relieved during the construction of the complete denture, but when these mandibular tori are large should be removed surgically. Thank you.